Okay, perhaps we should get going. Thank you. So welcome everyone to today's tech talk brought to you by the MPCCC. For those of you who don't know me, my name is Melissa Southey. I co-direct the MPCCC with Mark Shackleton. I'd like to begin by paying my respects to the traditional custodians of the lands from which we join together today, and pay my respects to their elders past, present and emerging. I'd also like to pay my respects to any Torres Strait Islanders and Aboriginal people amongst us today. So as many of you know, the tech talks are really an opportunity for us to talk tech. So they're meant to be conversational, they're meant to be a way of sharing people's experience with new technology, and especially, and perhaps really exciting today, to see ways that new technology can be developed and used in a diagnostic setting to deliver new information to patients with cancer and people perhaps predisposed to cancer, and improve the outcomes for those people. So today it could be conversational. I think our speaker would be open to people asking questions throughout the presentation. So it's low-key, it's not formal. It's meant to be a way of sharing ideas and sharing experiences with technology. So it's my great pleasure to introduce our speaker today, which is Dr. Pranav Dorwal, who many of you will know. He feels like a member of the MPCCC family, really, having worked with us I think for more than a year now as an MPCCC molecular pathology fellow, which has just been terrific. I think many of you know the MPCCC fellow program and have been part of many of the activities in which they contribute and make a fantastic contribution to what we do on a day-to-day basis. So Pranav is a molecular anatomical pathologist who works in the Department of Pathology at Monash Health. He has a strong interest in medical education and research and has more than 60 publications. He also holds an adjunct position with Monash University, where he's involved in pathology teaching for medical students. An amazing CV, and maybe if we have time at the end, we could talk a little bit about your training pathway too, because I think that would be of interest to some people online. So you're a diplomate of RCPath UK, an international fellow of the College of American Pathologists, and you spent time in the pathology services at MD Anderson and at Memorial, which must have been an amazing sequence of work experiences which bring you to Monash Health, and no wonder you're such an amazing contributor to all that we do, particularly our MTB conversations. So with that, thank you very much for joining us today and making this presentation, but I'll hand over to you, Pranav, to start your presentation.
Yeah. Thank you so much, Mel. Kind words. I'll just share my screen and hopefully that works. I hope that's visible now. Yep, okay. So thank you everyone for joining in. So what I'll be talking about today is it's a case-based discussion. So I'll be talking about some of the interesting cases where we have used the NGS-based fusion testing for diagnosis in most of the cases. In some cases, it may have therapeutic implications as well. So that's what I'm going to talk about. So it's most case-based, and please feel free to stop me if you have a question on a particular case. We can discuss that along the way. Just get my pen so I can scribble on the slides. Just briefly about the pathobiology of the fusion genes, which leads to oncogenesis. So the gene fusions can result from reciprocal translocation, insertions, deletions, tandem duplications, inversions, or chromothripsis. And there are various mechanisms how it can lead to oncogenesis. So it can there can be overexpression of an oncogene through promoter exchange, which is what happens, for example, in the Tempris-ERG fusion, which we see in prostate cancers. They could be, it can cause truncations, which may lead to loss of negative regulatory microRNA binding sites, for example, in MIB and FIB fusion, which we see in adenoid cystic carcinomas. There could be destruction of the intrinsic control mechanism through introduction of oligomerization domains, which we see in the kinase fusions like ELK, Antrag-RET, and ROS1. Again, a different mechanism by loss of autoinhibitory segment, membrane non-nuclear localization domains, which you see in BRAF fusions, and impairment of the function by destruction of the folding capacity of the protein, which you see in MLL fusion, seen in acute leukemias. There could be destruction of the regulatory role of a protein, which you see in NAB2 STAT6 fusion, seen in solitary fibrous tumors, or in case of PML-RARA, which we see in acute promyelocytic leukemias. So what's the how it has come into being? So traditionally we have used chromosomal analysis, FISH and RT-PCR to detect gene rearrangements. And all the technologies have their strengths and weaknesses, but where the NGS-based testing helps is that the traditional methods, you can only look at one or a limited number of fusion partners, whereas, and we know now, like some of the tumors can have several fusion partners to one gene. So if you're looking for a particular fusion, and if it's negative, doesn't mean that it's not present. There may be a different partner which you're not looking for in that particular case, for example, by performing a FISH assay. So the assay that we use here at Monash Health, it's a hybrid capture method, and that uses the probes which target 507 genes for recurrent translocations in various cancers. And we use the unique oligonucleotide indexes to help with the multiplexing. And this is the gene list. Obviously, we're not going to go through that, but just an idea of it's quite a comprehensive panel. So most, if not all, of the relevant genes which are currently relevant to diagnosis or therapeutics in solid tumors are there. And the important thing is that you only one of the partner genes for a fusion need to be in that panel for us to detect it. And a very good example of that is the cases with calcified chondroid mesenchymal neoplasm. Now, this is again an emerging or a new entity where you find FN1 rearrangements. Now, this FN1 rearrangement, and you can, if you go through the list, you can see there's no FN1 in this panel, but the partners for FN1 are common ones, like for example, FGFR, which are present in the panel. So those fusions can be picked up. And the process, it's only the first step, which is slightly different to the DNA-based analysis. So you extract RNA and then you, which undergoes reverse transcription. So you get the cDNA, and rest of the process is similar to a DNA-based assay. Now, bioinformatics is a crucial part of this test. And we use the Illumina Dragon RNA app, which aligns the reads against the RNA fusion reference genome, which is essentially a modified version of the AG19. Now, after that, there's splice aligner, which perform the split read analysis on chimeric alignments to detect potential breakpoints. So you put in the FASTQ files, and what comes out are the BAM file, which will have the aligned reads, the CSV file, which will have the fusion candidates, and sj.out file, which will have splice junctions. So if you have a spliced variants leading to fusions, for example, in MET exon 14 leading to MET exon 13-15 fusion, that can be detected using it. Now, what we are looking for in the assay are the supporting reads, which can be of different types. So you can have spanning reads, you can have split reads, or hybrid read, which is just a combination of the spanning and the split reads. So for the spanning reads, both paired end reads span the fusions, as you can see here. So that spans the fusion. The split reads have paired end reads in the different gene fusion partners, so they're not spanning the fusion. So which you can see here. And in hybrid read, there'll be one read, which will be spanning read, and one read will be a split read. So that's what we're trying to look for. And obviously, you set up your cutoffs to look for these fusions. Any questions at this stage before we move on to the cases? Okay, I guess not. So we'll move on to the cases. So the first case is a 19-year-old female presented with large peritoneal mass. And considering the age and the site, and these were the differentials, so clinically they thought, could it be lymphoma or ovarian cancer? And this is the PET scan. So you can see it's a large tumor which is occupying most of the peritoneal cavity. And this is how it looked on H&E stain. So you can see just at this part, we can see it's a pretty poorly differentiated tumor. Possibly there's some necrosis in some areas. A higher part view, again, a very, very poorly differentiated morphology, essentially a small round blue cell tumor. But then you have some areas like this, which have got a slight spindling or streaming of the cells. And as we do with these tumors, you perform a panel of immunohistochemical stains, which we did in this case. So you can see the A1, A3, which is pan-cytokeratin, to look for epithelial differentiation, was negative. CD56 was positive, which is a very, very sensitive marker, but again, fairly non-specific. You can see it, obviously, traditionally it's been considered that it's a neuroendocrine marker, but you can see it across various tumor types, which was positive. And considering that we were trying to exclude a neuroendocrine tumor, it's synaptophysin, which was negative. CD99 was done to look for something like an Ewing sarcoma, which was negative, but then Desmond was positive. So possibly some kind of a muscle differentiation happening there. And then WT1 was positive. So, and again, it was a bit patchy. It was not strongly positive. It was a bit of a patchy expression for WT1. And so this was the profile. So it was positive for Desmond, CD56, patchy positivity for WT1, and negative for all these markers. And then and morphologically and immunohistochemically, there was suspicion that it could be a desmoplastic small round cell tumor, although the keratin was negative, which is usually positive in these cases. But as we always say, tumors don't read books or journals for that matter, so they can have kind of a bit of a variation to the norm. So in this case, we picked up EWSR1, you can see here, with a WT1 fusion, which is diagnostic for desmoplastic small round cell tumor, which is what it was. And we know with the EWSR1, you can get EWSR1 fusions along with varying tumor types. So that's why it's very, very important to know what the partner for EWSR1 is, which in this case was WT1, which is fairly specific for desmoplastic small round cell tumor. You don't see that in any other tumor. And we'll come across other fusions later on, which are seen in multiple tumor types. Okay, moving to the second case. So I've got a total of 16 cases. So just to give an idea of where we are in the talk. So this case 2 was a 61-year-old female and had a history of neuroendocrine tumor. And on a CT chest, you can see here, there's a well-defined rounded 14 millimeter lesion in bronchus intermedius. And obviously, given the history, that's what the suspicion was, that this might be another neuroendocrine tumor. And this was the tumor. You can see that's the respiratory epithelial lining, and the subepithelium has got this tumor, which has got some kind of a, you can see this is a hyalinized stroma and has got fairly uniform cells with moderate clear cytoplasm, but not so clear, and had kind of some kind of a neuroendocrine nuclear morphology. But again, considering this was lung, you'd always do a TTF1, which was negative. P63 was positive, and so was CK56, which is high molecular weight keratin. CD56 was very, as you can see, and I was talking about the previous case, it's rather non-specific, but it was positive. You can see it's a weak patchy positivity, but it's definitely positive there. And S100 was negative. So we didn't know what we were dealing with at this stage. There was suspicion for neuroendocrine tumor. So we decided to undertake the fusion testing, which then picked up EWSR1 and ATF1 fusion. And which is, in this case, in case of thoracic salivary gland type tumors, this is seen in hyalinizing clear cell carcinoma, but it can also be seen in edgematoid fibrous histiocytoma. But in this morphology, this was in keeping with hyalinizing clear cell carcinoma. And going back to the morphology, we can see some clearing of the cells. You can see obviously it is hyalinizing, which you can see, and there's some clear cell morphology. And then after this, it was taken out, which you can see on the screen now. So this was more typical how it would look, because obviously the initial biopsy was small. So and the tumor obviously can have varying morphologies in different regions, but this excision was quite characteristic for a hyalinizing clear cell carcinoma. This was the next case, a bit unfortunate, 70-year-old female. The clinical suspicion based on radiology was this is a patient had a fibroid, which you would expect in a uterine wall mass. And then after the resection of the so-called fibroid, hysteroscopically, the patient had uterine rupture. and obviously led to hemiperitoneum. And then after that, to manage that, patient undergo total laparoscopic hysterectomy and bilateral centric oophorectomy. And this was the tumor, and you can see obviously it was ruptured, so there's nothing around the tumor. That's the rupture site, and this is how the tumor looked. So again, obviously, those who deal with gynae pathology, they know it doesn't look like a typical fibroid. So you can see it's kind of epithelioid morphology, but vesicular nuclei with prominent nucleoli. So the suspicion was some kind of a stromal sarcoma. In some areas, it had this myxoid stroma, and the cells present as cords and trabeculae. Usually with the endometrial stromal sarcomas, the ones which are low grade, you would get CD10 positivity, which was clearly negative here. There was positivity for PR, which is progesterone receptor. There was a nuclear staining for WT1, but it was negative for desmin. And as on the lower right side, you can see this area, that's the myometrium, which is positive for desmin, but the tumor cells are clearly negative. CD99 was positive. Again, just like CD56, it can stain a lot of things. Again, a bit non-specific. Inhibin was interestingly negative in this case. AR, which is androgen receptor, was positive. And KR67 was rather low. It was not like a high-grade sarcoma, although KR67 is not usually used to kind of grade the sarcomas, but it kind of gives you an idea. So in this case, it was maybe around 10% or less than that, KR67, indicating possibly a low-grade tumor. And then surprisingly, on the RNA fusion testing, we found this fusion between ESR1 and NCOA3. So what does that tell us? So ESR1 and NCOA3 fusions are kind of diagnostic for uterine tumor resembling ovarian 6-cord tumors, or the acronym is UTROSACT. And some cases would have ESR1, some cases would have a GREB1 fusion as well. In our case, we had ESR1 fusion, but the ones which have GREB fusion, they are considered to have a poor prognosis. They occur in older women as compared to the ESR1 rearranged tumor, and they have increased likelihood of malignant behavior. Moving to case number 4, any questions at this stage? Okay, so I'll move on. Case number 4 is a 56-year-old male with left upper lobe lung mass, and patient had a history of fracture of right scapula, and there was a 2.5 centimeter speculated lesion in the lingula, abutting the oblique fissure, and obviously it's a lung mass. You would think of a lung primary, and this was the tumor. This was the core, which had, just on this part we can see it's a bit hyalinized tumor, and these are the cells which look moderately pleomorphic and have kind of moderate to abundant eosinophilic cytoplasm. But what is striking is that a lot of them have got these intracytoplasmic vacuoles or lumina formation, which was quite characteristic. And again, to see if it is a carcinoma, we did the A1, A3, which might look positive, but it's actually negative in the tumor cells. So what it is staining is the alveolar lining cells, but the tumor cells in the middle, which are kind of filling up the alveolar spaces, are negative. And corresponding to the A1, A3, we can see TTF1 positivity, which is nuclear, but again staining the alveolar lining cells, but negative in the tumor cells. S100 was also negative, but what was positive was CD31, which is a vascular marker. Similarly, it was also positive for CD34. ERG was also positive. So all these three, CD31, 34, and ERG, are kind of vascular markers, but ERG can also be seen in prostate cancer, so which we'll have a case later on in the talk. So ERG was positive, and to make sure it's not a metastatic prostate cancer, we did NKX 3.1, which was negative. So this was the overall profile. So it was a vascular tumor of some description. We favored it to malignant, sent it out to a sarcoma specialist, and they gave the differential that it could be an epithelioid angiosarcoma. But obviously, we wanted to make sure it's not a epithelioid hemangioendothelioma. which is what it was. So on the fusion testing, we detected WWTR1 CAMTA 1 fusion, which is diagnostic for epithelial hemangioendothelioma, and it's not seen in any other tumor. So considering the phenotype, the morphology, and the molecular findings, that's what the diagnosis was. And going retrospectively, in case of lung, that's how it usually presents. It fills up the alveolar spaces. That's the characteristic pattern of this tumor. Case number 5, 7-year-old female, so a child with a right bronchial lesion. And on CT scan, it was a 11 millimeter endobronchial mass in the right main bronchus. Radiologically, they favored it to be carcinoid or less likely to be salivary gland neoplasm. We don't expect primary lung malignancy in that age group. And this is how it looked. You can see this is the respiratory epithelial lining, and this is the tumor here. Again, it's got abundant bubbly cytoplasm, some mucin formation possibly. And then the tumor cells are positive for BuRE-P4, which is essentially an epithelial marker, and CK7, negative for CK20, and negative for synaptophysin, because obviously we're worried about carcinoid tumor or neuroendocrine tumor. The synaptophysin was negative. Ki67 was low, so it was some kind of based on this, it was some kind of a low-grade epithelial tumor, but we're not sure of what it was. And then on the RNA fusion testing, we picked up this fusion, CRTC1 mammal2, which is diagnostic for mucoepidermoid carcinomas. And majority of them, they usually have CRTC1 mammal2, but some cases, the minority of the cases display CRTC3 mammal2 fusion, which is what we had. And anything that is weird and wonderful, we always joke around that comes to Monash. And then even in this case, this was the rarer fusion transcript that we detected, and that was mucoepidermoid carcinoma. And with this fusion positive mucoepidermoid carcinomas, it is documented that they are picked up at earlier stage with lower grade and have a better prognosis than fusion negative carcinomas. Okay, going on from the theme of the uterine masses, this was another uterine mass in a 47-year-old female. On MRI, there was a large left lateral wall uterine mass concerning for malignant tumor with no extra uterine disease. And this was the tumor. You can see it's a very, very blue looking tumor, has got that stromal look to it. And it was kind of traversing through the myometrial fibers. And again, it has got that stromal pattern. And characteristically, it was positive for ER. So there was no problem in the diagnosis. It was positive for ER, CD10. So it was a endometrial stromal sarcoma. But the question was raised when it was discussed in one of the meetings, gyne-oncology meetings. One of the pathologists found an area which they're worried about high-grade morphology, so high-grade stromal sarcoma. And this area had like a weaker CD10 and ER expression, but again, you can see this is cyclin D1, which is positive in high-grade sarcomas. And this is not really strong, but it's kind of a patchy, weak positivity. But definitely, it was concerning in that area. So that particular block was tested, and this is the fusion that was picked up. So Jazz F1, you can see here with SOS12. And how was it helpful? Because this fusion is seen in endometrial stromal nodules and low-grade endometrial stromal sarcoma, not in the high-grade endometrial sarcomas, which will have a separate fusion, YWHAE, NUTM2, or the BCOR fusions. So this helped us kind of make sure that it's a low-grade endometrial stromal sarcoma rather than high-grade endometrial sarcoma. Okay, case 7 was an 81-year-old male, previous history of pleomorphic adenoma, the right parotid gland, which is now increasing in size and growing. So the worry was like, is it a malignant transformation in a pleomorphic adenoma, which is well known? And you can see this is the tumor here, and it has kind of gone through the skin and it's coming out now. So obviously it's transforming. And the patient had a documented history of pleomorphic adenoma in maybe 5 years ago, I think. And that's the tumor. Again, very blue-looking tumor, kind of fairly monomorphic cells. You don't see any high-grade features as such. And again, round regular nuclei, pale to clear cytoplasm, so kind of a myoepithelial kind of a look. And it's positive for pancytokeratin, which is A1, A3, also positive for P63 and SOX10, so a myoepithelial immunophenotype. And on IgV, we picked up PLAG1 with FGFR1 fusion. Now, again, that was not unexpected. The patient was a known pleomorphic adenoma, and pleomorphic adenomas are known to have PLAG1 rearrangements. And in some cases would have HMGA2 rearrangements as well. So that was not something which was unexpected. But the interesting finding was that the partner for PLAG1 in this case was FGFR1, which can be seen in pleomorphic adenomas. It can also be seen in myoepithelial carcinomas and in myoepithelial carcinoma, which have arisen in a context of a previous pleomorphic adenomas. So, and it's again, it's documented, and that's a reference at the bottom, that FGFR1 PLAG1 fusions are enriched 15-folds in myoepithelial carcinomas, which have arisen in previous pleomorphic adenomas. So what the message is that in these cases, which have FGFR1 as a partner for PLAG1, there is high risk of transformation to a carcinoma. Next case is a 25-year-old male, left posterior neck lesion, and on the core biopsy, initially it was diagnosed as a neurofibroma. And you can see the lesion here, and on this, you can see it's a pretty circumscribed lesion. And this is the low power view of this lesion. You can see it's fairly well circumscribed. In this part, it's got this zonation. So we can see some areas which are have low cellularity, other areas have higher cellularity. So that kind of a pattern. We can see there are some areas which are rather fibrous, other areas which are more myxoid. And we can see this typical vasculature, which is the curvilinear vessels. And this is an area which shows this abrupt transition from this myxoid areas to more cellular appearing areas, which are characteristic for this tumor type, which was positive for MUC4, BCL2, and CD99. So in this case, the diagnosis was kind of made on morphology and the immunohistochemistry of a low-grade fibromyxoid sarcoma. But this was done just to confirm that, and these cases usually have this characteristic rearrangement between FUS and CREB3L2, which is what we picked up here. So the rearrangement in FUS and CREB3L2 or FUS and CREB3L1 is diagnostic for low-grade fibromyxoid sarcoma. And this can also be seen in a sclerosing epithelioid fibrosarcoma, which is kind of essentially considered to be in a continuum with low-grade fibromyxoid sarcoma. So they're kind of morphologically and molecularly related tumors. This is a lung adenocarcinoma case, case 9, in a 55-year-old female left upper lobe lung lesion, an adenocarcinoma which was ELK IHC positive. Due to some reason, possibly technical, it was negative by FISH. And by the time it came to us for fusion testing, and we had very little tumor, but still we were able to pick up the rearrangement between EML4 and ELK, and which is the common fusion fusion partner for ALK in the lung cancer setting. So apart from lung cancer, you can see ALK rearrangements in anaplastic large cell lymphomas and neuroblastomas, and obviously they can be treated with ALK inhibitors, which are on your screen. But the important point here is that based on which exons are involved, these ALK EML4 ALK fusions have got various variants. Like this is, so 8 variants, variant 1, 2, over to 8, and this depends on which exons are involved. The most common ones are variant 3 and variant 1, where the exon 13 and exon 6 of EML4 are involved. Now, the significance of that is that the variant 3 have shorter progression-free survival when treated with tyrosine kinase inhibitors when compared to those with variant 1. And the reason is that the variants 3 tend to develop resistance mutation more commonly in contrast to variant 1. So this was an important important in this case. This could be another important finding which can be detected with this fusion testing. Next case is a case of a 31-year-old female left frontal brain tumor, and this is how the tumor looked. And you can see most of it looks like fairly mature lymphoid cells, but there are some larger cells interspersed between them. But obviously they're difficult to pick up in that quite a busy lymphoid background. But then these cells are highlighted by ALK. So you can see these larger cells are positive for ALK immunostain. They're also positive for CD30. And other stains that were positive were CD68 and CD163, which are both kind of histocytic markers. CD43, which is essentially pan-heme marker. LC or CD45 was weak, and CD4 was weak as well. CD3 was, because of the lot of background T cells, it was very difficult to appreciate the CD3 findings in this case. So the distinction here was whether this is an anaplastic large cell lymphoma or is it an ALK positive histiocytosis, because that overlap. CD4, although you would think it's a T cell marker, can also be seen in histiocyte macrophage lineage. And as expected, there was an ALK positivity. You'd expect an ALK rearrangement, but the important thing again in this case was the partner for ALK. So the partner here was NPM1 with ALK, which is seen in anaplastic large cell lymphomas and not in ALK positive histiocytosis. And again, this will have therapeutic implications. So the patient can be treated with crizotinib and alectinib. On the other hand, ALK positive histiocytosis is again a fairly recent entity. So this is an article from 2018, which describes ALK positive histiocytosis. And the important thing here is that the fusion partner for ALK in this case is a KIF5B. So KIF5B ALK fusion is seen in ALK positive histiocytosis. I think in our setting, we have seen that in one case a couple of years ago. So that's how it helped us in reaching diagnosis of anaplastic large cell lymphoma rather than ALK positive histiocytosis. Case 11, 71-year-old male with a large left retroperitoneal mass. See, it is 177 millimeter large mass. And this is the H&E slide of this mass. You can see it's again a very, very poorly differentiated blue-looking tumor, which shows positive for A1A3 pancytokeratin, also positive for CD99, and positive for ERG, and also positive for FLE1. So because of that CD99 positivity and positive for FLE1, the clinical concern was, is it an Ewing sarcoma? But to a surprise, what we picked up was a fusion between TMPRSS2 and ERG. And that's what was causing the ERG positivity on IHC. And TMPRSS2 and ERG fusion is characteristic for prostate cancers. So the patient didn't, they were not aware that it's the patient has a history of prostate cancer. There was no history as such. And again, that we have to be careful with ERG positivity. Although it's considered more like a vascular marker, it can be seen in prostate cancers. And in this case, the partner for ERG was TMPRSS, which helped us point in direction that it could be a metastatic prostate cancer. Following that, the tissue was subjected to immunostaining with NKX 3.1 and PSA, and you can see it was positive. The serum PSA was 1810, which was high, and the MRI confirmed the origin from prostate with extra prostate extension. So fairly poorly differentiated tumor from the prostate with ERG expression. Case number 12, 12-year-old male with large intra-abdominal mass. And this is the tumor, fairly hypocellular. You can see it's again very few cells there for us to examine. A lot of inflammatory cells in the background, and with again epithelioid looking cells with this traversing blood vessels. And this was the phenotype. I don't have images to show you, but they were positive. The neoplastic cells were positive for desmin, CD99, and ALK. And they were negative for myogenin, pancytokeratin, CD56, synaptophysin, and CD45. And the diagnosis was essentially made on that it's likely to be an inflammatory myofibroblastic tumor. And that's what it was. We picked up a ALK rearrangement. This time the partner was RAN-BP2. And the IMT is an inflammatory myofibroblastic tumor that involves mesentery. This fusion is seen in the epithelioid variant of it, and they are known to have an aggressive clinical course. So that was the mode of prognostic significance in this case, where we picked up RAN-BP2 and ALK fusion. Again, with all kind of ALK fusions, regardless of the tumor or the site, and they can benefit from ALK inhibitors. Any questions at this stage? Nope. Okay. So we'll move on to case number 13, which is a 70-year-old female with recurrent sinonasal tumor. So that's the tumor. You can see it has got a papillary kind of a pattern on low power. On high power, it's got this fairly rounded nests. And I think initially it was biopsied or sampled in 5 or 6 years ago, where they're concerned that is it a sinonasal papilloma versus a fairly well differentiated tumor which has got pushing borders. Again, although the thing thought it could be a well differentiated tumor, you don't see much differentiation that you would expect in these tumors. And not surprisingly, it was positive for CK56 and P40 and negative for P16. So likely this tumor was not HPV associated, negative for chromogranin and S100. And on fusion, because this was an old sample, so you can see the reads for AFF2 are not many. So, but then this fusion was detected, DEC and AFF2 fusion. Again, this is another recently described entity, DEC AFF2 squamous cell carcinoma, which is a subtype of non-keratinizing squamous cell carcinoma, commonly seen in the head and neck region, nose, paranasal sinuses, skull base, and commonly seen in the HPV negative tumors, which we saw in this case. It's got exophytic endophytic growth, and again, it's doesn't show that much of a squamous differentiation morphologically. And then they have this typical tumor infiltrating neutrophils or lymphocyte, which can give an idea that this could be this tumor. Although the morphology is rather bland, but I think the important thing is that it has got an aggressive clinical course and has multiple recurrences, if not removed completely, which was the case here. So the patient had a couple of recurrences. Case number 14, 70-year-old male, large vocal cord lesion. So that's the lesion here. So on the higher part, we can see that's the squamous lining, which looks unremarkable. Then we've got this tumor, which is quite myxoid with these again curvilinear vessels. There are a few larger looking cells, which are like a bit worrying for a sarcoma, but there are a lot of inflammatory cells in the background. So and it was positive for ALK. So morphologically and phenotypically, it was in keeping with an inflammatory myofibrotic tumor of the vocal cord. It was negative for keratin, MUC4, and ERK. And this was the fusion. So it was a fusion between ALK and TIM3. And again, this is has been described as TIM3 ALK fusion has been described in vocal cord IMTs. And this is the most common fusion partner for ALK in head and neck tumors. And this was a series of 7 cases where this tumor was described, and it was labeled as a myxoid fibroblastic tumor of the vocal cord. And this fusion can also be seen in uterine or pregnancy-associated IMT cases. And as I said previously, they can be treated with ALK inhibitor, for example, crizotinib. Now, this is the second last case, a 33-year-old male lower lip vestibular lesion, which was a 20-millimeter lesion, which you can see here. Again, it's a fairly well circumscribed tumor, as you can see. It's fairly cellular in the central areas, and there were some areas of necrosis, like in the periphery. You can see these paler looking areas. These are all areas of necrosis. And it has got these fascicles of which look like a smooth muscle tumor to a trained eye. And the mitotic activity was not super high, but because of necrosis, there was this worry that is it some kind of a aggressive smooth muscle tumor. And as you would expect with the smooth muscle morphology, it stained for actin, desmin, and keldesmon, but was negative for keratin, S100, and SOX10. And this was the fusion SRF with NCOA2. And again, that has been described in cases of cellular myofibromas or myopericytomas, which we have seen a few cases of. But again, the important thing is that these can be easily misdiagnosed as sarcoma, which was the worry in this case. We saw that there was areas of necrosis, but it was again a very, very circumscribed tumor, and it was cellular tumor with few mitoses. And they have smooth muscle morphology and phenotype, but the mitotic count is low, which was the case here. We didn't see this coarse calcification, which has been described characteristically in these tumors. But although the number of cases that are reported for this entity are limited, but they tend to behave in a benign fashion. So because this can be easily misdiagnosed as sarcoma based on morphology, so that's where it helped in this case. And this was the publication that we had last year. So we had a series of 3 cases, but in all the 3 cases, there were different partners, RELA, NFK, PIE, and NCOA3, and one of them, I don't remember which one, I think one was a novel fusion partner for SRF. This is the last case, 45-year-old male with supraclavicular lymphadenopathy. On CT scan, patient had right upper lobe mass suspicious for primary bronchogenic carcinoma. There was a right middle lobe pulmonary nodule, which was suspicious for metastasis. There was extensive mediastinal and right hilar adenopathy encasing and narrowing the superior vena cava. And there was right supraclavicular adenopathy, which was sampled. So this was the tumor. Again, a very, very poorly differentiated tumor. And it stained for A1, A3, P63 was patchy. It was negative for S100, TTF1, CK7, PLAP, and CD45. So initially it was reported as a poorly differentiated carcinoma. And then it came for the lung or thoracic MDT, and one of our pathologists, Dr. Eric Hu, he looked at it and he had this concern that it could be a tumor which could be a nut carcinoma. So he ended up performing the nut immunohistochemistry, which, as you can see here, was positive in this case. So that gave the diagnosis that it was a nut carcinoma. And they usually have this fusion. In this case, it was a nut M1 with BRED3 fusion. So nut carcinomas are poorly differentiated tumors associated with translocation involving the nut gene. And then they're usually in the midline, and that's why they're called as nut midline carcinomas as well. Majority of them occur in the head and neck and thoracic regions, but uncommon sites are soft tissue, bone, kidney, bladder, pancreas, and thyroid. The most common fusion partner for nut M1 is BRED4, and as I was saying, we always pick up the less common ones. So we picked the fusion that we had was BRED3, which is seen in the minority of the cases. The fusion partner is important in this case because the prognosis depends on that. And overall, this tumor has got a very, very poor prognosis. The overall survival is less than 1 year. But relatively, the ones which have got BRED4 fusions have a poorer survival as compared to the tumors which have got non-BRED4 fusions. For example, BRED3 in this case. And these are some of our recent publications coming out of this essay. And the take-home message that I would say is that when undertaking a molecular test, including fusion testing, we should have a specific question in mind. It's very rarely that you'll find surprising results that you can blindly order it and then get results, which happens. Like we had some cases that we saw, especially the prostate one, where you came up with the surprising results. And it's also important to understand the limitations of the assay. So we should, when especially interpreting these results, you should know what the panel included, what it didn't include. So you may assume that there's no fusion, but maybe that fusion was, that gene was not part of the panel. Also, you have to know the limitations of the tissue. Sometimes, especially with the RNA-based assay, if the tissue is very old, it's likely it's not going to work. And also some of the fusions can be found across various tumor types. So it doesn't mean that you picked a fusion that will tell us what the diagnosis is. And it can range from very benign tumors to highly aggressive tumors. And I would like to thank our amazing team. So whatever I presented today is a cumulative effort of all of us. So Anna, Amit, Prof. Kumar, Ben, Broden, Eric, Jade, Janice, Julie, Leanne, Mary, Noel, Pam, Pat, Paul, Peter, Pinky, Priscilla, Ravi, Rob, Suzanne, and Wendy's. So thank you to our amazing team, which has been able to put out such amazing results for me to present. Thank you.
Hey, Pranav, can I ask a question? Sorry, I think you're muted. Just
I
with
muted, yes.
that case with the prostate carcinoma of the erg temporis, I'm not sure if I misheard. Did you say that one had fly1 staining?
Yes, it did have
Is there
fly1
a
staining.
reason why? Does
I
it?
don't know.
All right. Okay.
Yeah. So again, as I said, that you can have like overlapping staining. Usually you expect a fly1 fusion, right? And that's what the concern was in that case, that it could be an Ewing sarcoma with fly1 rearrangement, but it was not.
Interesting.
So the immunostains can be tricky sometimes.
Thanks. That was really interesting.
Southey, perhaps you could take us off slide show and put us back so we can see each other. Can we put the gallery of? Maybe we can't. Oh yeah, there we go. Everyone's got their camera off. Maybe I turn on. Could you play? Thanks so much, Pranav. That was amazing. Maybe I could just. How long have you been conducting this test in?
This has been, so it's been like a little over 2 years, I'd say. So maybe early 2022. Yeah.
You showed us an amazing series of cases which, consolidated into your points at the end. But can you give us some perspective? How often are you using this information in your day-to-day work? Is it, once in a blue moon, or is it really a
No, it's quite common. So essentially, I would say we have one run every week. So yeah, it's quite commonly used nowadays. So.
And this point about having a question before you use it, I'm aware that you're generating so much more data than you've shown us to help you with that diagnosis. Do you ever go back to the rest of the cDNA information and ask additional questions to further get into a diagnosis, or really very focused on the fusion?
Yeah, at this stage it's very focused because that's the scope of the test as per NART accreditation. So I'm aware, I understand your question that there's too much data and we can look into it further. But again, that's a very important question and can be done, but not at this stage. Yeah.
If you don't need to get to your diagnosis. Yeah. I'm sorry, that question came from a researcher.
Yeah, no, absolutely. And that's a fair question, isn't it? Like there's so much data which we can use. Yeah.
So where do you think from here?
Yeah, we are looking to expand the panel as well. So yeah, that's the next step. There's a question.
If you have a question, please you're welcome to put the camera on and just ask.
Yeah, there's a question from an anonymous attendee, which is how many more MET exon 14 skipping events can be picked up on a fusion test versus DNA test? So for MET exon 14, I would say that this current panel doesn't have MET gene on it. So this would not pick up the MET exon 14 skipping variants. So I don't know is the answer. So in our setting, we use the DNA test to look for the MET exon 14 splice site variants to predict MET exon 14 skipping.
Anybody else have more questions? I don't know whether Bina would like to offer anything about the future of all of this, where things might go from here.
Yeah, I think it's what the progress we've made over the last 2 years has been phenomenal. And as Pranav rightly said, it's a team effort, and we've got very good scientific and medical staff working on this. And Pranav, of course, leads the reporting of all these cases. And so we have the pan cancer, the big panel now, which is part of it's equivalent to the foundation one. I won't say it's exactly that, but the genes covered are sort of similar. So that's the next thing which we've, sorry, I'm not able to put my camera on. That's fine. I'll talk. And then the work, we can see that the work volume has certainly gone up, both for the DNA and the RNA fusion panel. And, anytime more support, we are happy to get involved in clinical trials, research projects, and wherever we can sort of step in and help, definitely. Yeah. And we are also looking at some germline panels, not exactly germline, more in the cancer space, BRCA1, 2, exactly, and other genes, which we currently, they're all send away tests at Monash. So we are trying to bring them in-house. And with the Victorian Heart Hospital coming up, we are also developing the cardiac panel for cardiomyopathies, arrhythmias, and hypercholesterolemia, etc. So that's where we are busy at the moment.
There's another question from another anonymous attendee saying, how long does it take to go from the sample to the report? So for this essay, we promised 2 weeks, but usually we end up reporting slightly earlier, depending on when the sample arrives in the batch. But the promised turnaround time is 2 weeks from the receipt of the sample.
So you do it on a fairly small format, clearly. What sort of batch sizes do you run?
So we run a eight samples as a batch size. Don't see any questions in Q&A now.
I'm sorry I've missed those, but I think we've got them all. Well, clearly we need to have you as a regular feature on these talks because things are moving quickly, and to see them actually in practice in your team's hands is really, really phenomenal. And I guess to see not only it clinching a diagnosis, but actually influencing treatment choices is, I guess, where many of us are really invested in our research and our practice, to take all of this new technology into not being letting tech drive us, but letting the tech be useful in all of our systems. So thank you so much for the amazing 16 cases that illustrate that so clearly across the spectrum. Also with pediatrics, do they come across from the hospital on site? Or?
Yeah, so some of them are, most of them are Monash, and obviously, as you said, a lot of them come from the pediatric children's hospital as well. And they are the ones which are urgent and super urgent, as you'd expect. But we also get a lot of cases from external providers.
Right. Great. Okay, well, if there really aren't any more questions, I think everyone's just absorbing all the information. And I'd just like to thank you so much for presenting that. That was wonderful. And again, I really hope we can have you back, perhaps in 6 months or something, to show us where the next frontier has taken us. So thank you so much.
Thank you for having me.
Thank you. I believe there'll be some recording up soon on a website if people want to play it at half speed to absorb everything that you were saying. But thank you so much for the presentation. Very, very enjoyable.
Thanks, Melissa. Thanks, Pranav.
Thank you, Sarah.
No worries.